Good afternoon, everyone. My name is Morgan Gargiulo from the New England QIN-QIO, and I'll be your moderator for today's webinar, Measuring MIPS Performance, Optimizing Your EHR for ACI Success. Sorry, that's a mouthful. Before we get started, I wanted to go over a few housekeeping items. This call will be recorded for training purposes, and I'll provide you details on accessing the recording at the end of the webinar. I have muted the phone line for the duration of the presentation, and we'll take questions at the end. But if you would put your questions in chat throughout the presentation, we'll keep up with them then, or you can ask your question at the end. So thank you for joining, and I'll now pass things over to Leila to get us started.
Hi, everyone. Welcome to today's webinar. My name is Radhika Sapnis, and topic for today's webinar is maximizing for MIPS, and in particular, we will be deep diving into how you could optimize your EHR for ACI success. Next slide. This is a small disclaimer that we are funded by CMS, but this material was prepared by health-centric advisors, and this is just meant to be a general summary. Next slide. This is a quick overview of the presentation. First, we'll be giving you a brief introduction about MACRA, and then a little more detail about the payment track, and then deep diving into advancing care information and the specifics of it. And then we'll be also talking about the resources available to you and eventually opening it up for questions. Next slide. Here are the few acronyms that we will be coming across, like CMS, Center for Medicare and Medicaid Services, EHR is Electronic Health Records, QPP is the Quality Payment Program, EC is Eligible Clinicians, and as and when we come across more acronyms, we'll spell it out for you. So what is MACRA? MACRA is the Medicare Access and Reauthorization Act. It was enacted in April 2015. It's a bipartisan legislation that repeals the flaw of sustainable growth rate in effort to reduce Medicare spending. MACRA created the Quality Payment Program, which included two payment tracks. One is MIPS, that's Merit-Based Incentive Payment Systems, and other is Alternative Payment Models. Quick highlights for the two tracks. Starting with MIPS, if you're participating through MIPS, based on your performance, you may get up to 4% positive payment adjustments. Other highlight is there are 3 reporting phases available for 2017 transition year. And if you decide you don't want to participate, then you will get a 4% negative payment adjustment. The other track, APM, or if you're participating through APM, you will get a positive payment adjustment based on your performance at 5%. If you are participating through MIPS APM, you will receive a favorable MIPS scoring, meaning there is no downward financial risk to this particular model. And if you are participating through advanced APM, this follows a risk structure. So based on your performance, you may get either a positive or a negative payment. Going more into the details of MIPS, MIPS basically consolidates 3 legacy programs that were available earlier. First being the PQRS, which is known as Physician Quality Reporting System. The other one is Meaningful Use, which is the EHR Incentive Program. Third is the Value-Based Modifier, Payment Modifier. So how are these included in the MIPS payment track? PQRS is now the Quality Performance category. Meaningful Use is now the Advancing Care Information. Improvement Activities is a new activity, new performance category that they've introduced, and Cost is the Value-Based Payment Modifier. Going into the details of performance categories, starting with Quality. Quality accounts for 60% of your total MIPS score. An eligible clinician must report on 6 quality measures out of 270 that are available. One has to be outcome or a high priority measure. Next is improvement activity. This accounts for 15% of your total MIPS score. An eligible clinician must report on 1 to 4 activities out of 90 available. There are 2 types of activities that are available: high weighted and medium weighted. High weighted would give you 20 points, medium weighted would give you 10 points. But if you're a practitioner who belongs to small or a rural practice, then you just need to report on one or two activities because the weightage of these activities double up. The third category is advancing care information. This accounts for 25% of your total NIPS score. All eligible clinicians must report on base measures, and if you want to score more in this category, you can also submit data on performance measures. Last category is the cost category. This accounts for 0% in this year for this transitional year, but CMS will provide you feedback at the end of the year. Next slide. Coming on to the eligibility and exclusion criteria. Who are eligible for MIPS? Physicians, by physicians I mean doctor of medicine, podiatrists, chiropractors, dentists, doctor of osteopathy, ophthalmologists, and doctor of surgery. Also included are physician assistants, nurse practitioners, clinical nurse specialists, certified registered nurse, anesthetists. So what is the low volume exclusion or what is the low volume threshold? The clinicians that submit less than $30,000 in Medicare Part D claims annually, or clinicians that care for fewer than 100 Medicare patients annually are excluded from it. Also, clinicians that are submitting their Medicare claims for the first time this year will be excluded, as well as the clinicians that are participating through advanced APM will be excluded from MIPS. CMS has introduced 3 phases for reporting this year. But the very obvious option is you can choose not to report, you can forego reporting entirely, but you're bound to get a negative 4% adjustment in 2019. However, if you decide to report, your first option is what we are calling the crawl phase, and the reporting period for this particular phase is less than 90 days period. What do you need to report is one quality measure for one patient at one time. However, if you're determined to avoid a negative payment adjustment, we would advise or we would recommend that you report data on at least 20 patients for a period of 1 month so that you avoid a negative payment adjustment. Or you could report on one improvement activity for a period of 90 consecutive day period, or you could report on required advancing care-based measures for a period of 90 days, or consecutive 90-day period. Your next reporting phase option is what we are calling as walk-up. Clinician may receive anything between 4.4 to 69 points. Reporting period, minimum reporting period required for this particular phase is consecutive 90-day period. What you need to report is on 6 quality measures, including 1 outcome or high priority measure, and 2 to 4 improvement activities depending on the weightage of activities you choose, and required advancing care information-based measures, plus any performance measures you would like to report for a minimum consecutive 90-day period. What you will receive is neutral or small positive payment adjustment. Important thing to keep in mind if you're choosing this phase is you cannot start later than October 2nd, 2017, because that will be your last consecutive 90-day period. Your last option is run, and you basically can report for a full calendar year. The eligible clinician may receive anything 70 and above points. What you need to report is 6 quality measures, including 1 outcome or high priority measure, and 2 to 4 improvement activities depending on the weightage. This has to be a minimum 90-day, consecutive 90-day period. And the last thing you need to report is required advancing information-based measures plus any performance measures in this particular performance category. What you will receive is a moderate positive payment adjustment and also an opportunity to receive an exceptional performance bonus. Next, we will be deep diving into advancing care information, and I'll hand over the baton to Leila.
Thank you, Radhika. Welcome, everyone. Thank you for joining us today. I'm going to be taking you into the advancing care information category a bit more, talking about the specific measures, We're going to talk a little more about how you can implement those into your practice and evaluate your electronic health record or EHR more and make sure that you have everything you need to be quite successful in this category. So as Radhika mentioned, the Advancing Care Information category accounts for 25% of your total MIPS score. Now, the way you get to the full 25% is kind of peculiar. If you look at this slide, you can see that the total category performance equates to 155%. And some of you are probably scratching your heads saying, how can you get over 100% in a category? And here's how. So 50% of that 155% comes from those required base measures, as Radhika mentioned. We'll talk about exactly what those are. Then there's 90% that can come from the performance measures. We'll also talk about what those measures are. And then there's an additional 15% that comes from bonus measures. As you can see, 50 plus 90 plus 15 equals 155. However, you are capped at 100%. As Radhika mentioned, you must report for at least 90 days. You can obviously report for a full year or any time period greater than 90 days, but it must be at least 90. That can't start any later than October 2nd. If you look at a calendar, October 2nd is the final day of the year. That would equal 90 days if you went from October 2nd to December 31st of 2017. For this performance category, there are 4 submission methods. You can report via attestation, which would be going into a portal, which has not been made available yet, and just keying in your data manually. You'll look at the measures and enter your numerator, denominator, and any exclusion populations. You can report using your EHR, and that's called EHR Direct. Your EHR will provide a report in some structured data field. Each EHR uses different submission methods. Sometimes they make a CSV file, that's sort of a different Excel version. Some use the QRDA data files. It really depends on the vendor. So I would work with your vendor if you're planning on using that method. The next option is registry, or QCDR is Qualified Clinical Data Registry. These are usually offered by specialty societies. So if you're part of, let's say, the American College of Family Physicians, I believe they have a registry. Again, it's similar to reporting data using EHR Direct. The registry will pull data from your EHR and then submit it directly to CMS on your behalf. The final option, if you are part of a group of greater than 25 eligible clinicians, is using the CMS web interface. That will function pretty much the same as a manual attestation, where you will go in and key in the numerator denominator values for each of the measures. So, the base measures, as I mentioned, this equates to 50% of that total 25 potential points. Clinicians must report on all measures within the required base measures. There is one measure, regardless of what EHR certification year you're using, that is a yes-no attestation. So if you're on a 2015 certified EHR, you can select to report using either the Advancing Care Information Measures, that kind of darker blue box, or you can choose to report using the 2017 Advancing Care Information Transition Measures. If you're on some combination of 2014 and 2015 certified EHR, you can also choose either the dark blue box or the lighter blue box. If you're on only a 2014 certified EHR, you may only select the 2017 Advancing Care Information Transition Measures. So important to know what certification year your EHR is. We'll quickly talk about the measures, and then I'll get into them in greater detail a little later on. So the security risk analysis, this is a yes-no. That's called attestation only. So you would just simply say yes or no, your practice is completing this. E-prescribing, obviously sending electronic prescriptions. Providing patient access has to do with providing patients access to a patient portal. And then send a summary of care as well as health information exchange has to do with sending an electronic summary of care. And request and accept a summary of care is requesting and accepting that electronic summary of care and then actually pulling it into your patient's electronic health record. Now, everything below the security risk analysis are numerator-denominator measures. In order to meet the required base score, you have to have at least one patient in the numerator for each of those measures. You could have 10,000 in the denominator and 1 in the numerator and have obviously not great performance, but you would still meet the requirements and pass the base score and get the full 50%. As it says at the bottom, failure to meet those measure requirements, so that 1 patient in the numerator or a no to the security risk analysis, would result in a 0% score for this base requirement, which would also mean you could not achieve any performance or bonus points as well. So you would get a full 0 for the final score on the advancing care information category. So what are the performance measures? The performance measures are a way to earn up to 90% additional bonus, well, it's not quite the bonus, but additional score towards your 25% advancing care information score. I'm going to quickly talk about the advancing care information 2017 transition requirements first, because it seems like a lot of the practices and clinicians we've worked with are on 2014 certified EHRs. So this seems to be predominantly what we're seeing, but as I mentioned, if you're on 2015, you can choose which path you want to take. So some of these measures probably look familiar. As you can see, provide patient access. This actually is up to 20% of your performance score. It's a great way to earn additional points, especially if you're doing a lot of work around patient portal utilization. Send a summary of care. Again, that's also a base measure. You can earn up to 20% for that as well. View, download, transmit is along the lines of the patient portal. So a patient needs to log in, view, download, or transmit their electronic health record. Patient-specific education. Again, that's utilizing your EHR to identify patient-specific education materials and provide them to the patient either through your portal or printing them out in the office. Secure messaging, also through the portal. That's messaging back and forth with your patient. Medication reconciliation, utilizing your EHR to reconcile the patient's medication. And finally, immunization registry reporting. This is another attestation only, so either you are actively participating with an immunization registry where you would say yes, or you are not participating where you say no. If you're familiar with previous years of meaningful use, the immunization or clinical data registry reporting was a required measure where if your state couldn't offer registry reporting capabilities, you would need to get an exclusion letter, basically stating the state didn't have the capabilities and thus you were excluded. Since this is just a performance measure, you're not required to report on it, so if you're not participating, you won't get bonus points, but you're also not going to get penalized. So a little flexibility there. As I mentioned, you can get up to 20% for those first 2 measures. The scoring for the other measures is on the side, so depending on your performance, so let's say you had 25% performance on patient-specific education, you would earn 3 percentage points towards your performance score. So it follows sort of a decile scoring system, but a little more easily defined than if you're familiar with the quality measure decile scoring system, which can be quite complex. Just briefly, here are the 9 advancing care information measures if you're utilizing a 2015 or 2014 and 15 certified EHR. As you can see, for the most part, these measures are all just about the same. To provide patient access, send and receive send a summary of care document, request and accept a summary of care document, all carry over from the base requirements. And then there's also the addition of clinical information reconciliation. So this is, again, very similar to the request and accept the summary of care. You're actually pulling in electronic clinical information into the patient's chart and utilizing it in a meaningful manner. Same scoring as before, up to 10 points for each of these measures. The first 2, as you can see, you can't earn up to 20. The 2017 only has 7 measures, hence those 2 are worth a little more. For bonus score, so 15 percentage points are available if you report on an additional public health or clinical data registry, so syndromic surveillance reporting, electronic case reporting, public health registry, or clinical data registry. You can get up to 5 bonus points. If you decide to report on more than one of these, let's say your state or your organization or any specialty society you're working with has capabilities to allow you to report on multiple, you can only earn 5 bonus points. If you report on more than one, it doesn't get you any additional points outside of the 5. We won't be talking a lot about improvement activities, but if you utilize your certified EHR in a manner that is consistent with some of the improvement activities, you can earn an additional 10 bonus points, and there's roughly 18 improvement activities that align with the EHR requirements. Just a quick slide for the base score, plus the performance score, plus the bonus score gets you your final advancing care information score. And again, that's capped at 100%, even though you can earn up to 55 ACI points. Just briefly, your entire MIPS score comes from 60% from the quality category, 15% from the improvement activities category, and 25% from the advancing care information category. Cost, as Radhika mentioned, is 0 for 2017. All of that is multiplied by 100 to give you your final score, anywhere from 0 to 100. Obviously, we're talking about ACI. As Radhika mentioned, based on all of the reporting paths, each reporting path gives you additional points based on how you report and your performance. If you decide not to report, you would be getting a 0 performance score, which would be a negative 4% payment adjustment. If you choose that crawl pace, so reporting on the very minimal amount of data, you would score 3, which would be neutral, so you would avoid a negative payment adjustment, but you would also not receive a positive payment adjustment. Performance scores of 4 to 69 points would earn a small payment adjustment, probably right around 1% of your Medicare Part D claims, maybe a little more than that. And if you score up to 70 points or above, you would earn a modest positive payment adjustment, so upwards of 4%. And if you're above 70 points, you also have the opportunity to get into what they're calling an exceptional performer bucket, which would get some portion of $500 million for all of the exceptional performers. So if you're looking to get a larger payment incentive, you probably want to shoot for a higher level of performance. You might be asking, previous years of meaningful use had hardship exceptions. If you're a clinician that's experiencing significant hardship, and so all of these measures and different opportunities for points just seem completely outside of your realm of being able to accomplish those, you might qualify for an exception. So the first opportunity for an exception would be insufficient internet connectivity. Not a lot of places qualify for this, especially in New England where I'm located, just because we have internet pretty much everywhere. So most of our clinicians don't fall into that bucket. The extreme and uncontrollable circumstances. Now that one seems to be coming up a little more often. So what that would include would be natural disasters. Let's say your practice closed because of bankruptcy. And the final one that we're actually seeing more commonly is that electronic health records are unable to meet the certification requirements, or for whatever reason end up sort of closing up shop halfway through the performance year. If for some reason your EHR just doesn't exist or doesn't perform to the level that you need, you might be able to get a hardship. So definitely look into that. We're happy to help you if you have questions. The final, which lines up to the next category I'll talk about, is the lack of control over the certified electronic health records technology, which is CEHRT. That really relates to clinicians in the hospital or facility setting where the EHR is given to them. They don't have a lot of control over the functionality, what's available, how it functions, really anything related to the EHR. They just utilize what's provided. If you do get accepted and your hardship moves on, your advancing care information score would be reweighted to 0%, so the 25% would be reweighted to 0, and that 25% would be moved over to your quality score. So quality then jumps to 85% of your total MIPS score, advancing care information is 0, and improvement activities are 15%. Now, if you're a clinician who, again, maybe has no control over your EHR, because you're hospital-based or in a facility, you might qualify for an automatic reweighting. So if you're a hospital-based clinician, which means that you provide more than 75% of your covered professional services in place of service 21, which is inpatient hospital, 22, which is outpatient facility, or 23, which is emergency department, you would be considered a hospital-based clinician, and your ACI performance category score would automatically be reweighted to 0. The same goes for physician's assistants, nurse practitioners, clinical nurse specialists, and certified nurse anesthetists. The other category of clinicians that would have their score automatically reweighted would be non-patient-facing clinicians. Now, those are typically radiologists, pathologists, clinical clinicians behind the scenes that aren't actually interacting with the patients in a face-to-face manner. There's a list of non-patient-facing encounter codes that we're happy to go through with you if you have questions. In order to be considered a non-patient-facing clinician, you have to have fewer than 100 patient-facing encounter types per year. So again, we can look at those with you if you're unsure and help you determine if you're in that group. So now we're going to talk about the advancing care information actual measures. And they all fall into 4 different categories, either patient engagement, care coordination, interoperability, or public reporting. So the first, as I mentioned, is provide patient access. Now this covers both 2015 and 2014 certified EHRs. For this measure, clinicians need to report on at least one unique patient seen by that eligible clinician. And now that patient or their authorized representative is provided with timely access to their online health record information. Now, this says view online, download, or transmit. Obviously, if you remember, that's a whole other performance measure, which we'll talk about in a minute. The important piece for a clinician is that they make sure that that patient's information is available to the patient. So are you providing an electronic after-visit summary right to the portal if the patient utilizes the portal? Do you update medications and send that to the portal? Do you update their problem list and send it to the portal? Do you provide their electronic education materials on the portal? And also, do you allow for electronic appointment scheduling and secure messaging back and forth? This advancing care information measure, if you know me and you've worked with me before, you know that I talk about it pretty much all the time because it hits so many different categories of performance within the MIPS program. So it's an advancing care information base measure, it's a performance measure, it's an improvement activity, and because it's an improvement activity that utilizes the EHR, it can get you advancing care information bonus points. So why is this measure so important? Well, outside of what I just mentioned on it touching pretty much all of the different aspects of the program, it increases patient engagement. So as we talk to patients, and as a clinician, and you want to make sure the patient's engaged in their plan of care and knows how to ask questions, this is a critical piece of engaging the patient. As I mentioned, it's a performance measure. This is the improvement activity it directly relates to, and then it's also the bonus for EHR utilization. The next measure, so this is from the 2014 Certified EHR 2017 Transition Measures. Health Information Exchange, it's also, I don't have it up here to the slide, header wouldn't take more text, but it's the same as the send a summary of care for the 2015 or straight advancing care information measures. But for at least one transition of care, so patient moves from your setting of care to a different one, or a referral, the MIPS eligible clinician that either transitions or refers that patient sends this electronic summary of care. And they electronically exchange that with somebody else. Now, what do we mean by a summary of care? This has to be a structured data report, usually following the CCDA data construct. There's about 15 required elements within that. We're happy to go over those at another time if you have questions. Oftentimes, this data report has to be sent in a manner that can be tracked and audited. So if it's electronic fax, that really isn't acceptable because you don't know who's receiving it on the other end. So while you might say, okay, well, I can generate this report, it has all the required elements, and then I just e-fax it over to whomever, you really don't know who's receiving it on that e-fax receiving side. So this needs to be sent through either your HIE, your Health Information Exchange. If you have some sort of direct messaging capability, often that's through an HIE, or some EHRs are set up to automatically send those documents. It needs to be sent in a structured manner. So why is this measure important? It really increases collaboration between clinicians and healthcare, different providers of healthcare in different settings. While sometimes it seems redundant, you're sending your referral report, you're sending this, you're sending that, why do I need to send one more document? It helps with that interoperability, making sure the patient's data is available in all settings of care. Again, this is important because it's a base and a performance measure. And then I listed a couple improvement activities that it relates to. So implementation of the specialist reports back to the referring clinician. So closing the referral loop, that's improvement activity CC1, or the bilateral exchange of patient information. So that's improvement activity CC13. It's also, as I mentioned, because an improvement activity counts as that ACI bonus for utilizing the EHR. And then it's also a quality measure. So if you're looking for ways to maximize your points and you're doing all this work, you can count this as a quality measure. So it's closing the referral loop, or it's quality ID 374. We try to maximize your points by things you're already doing. So hopefully you can get extra credit. Similar to this is for the 2015 certified EHRs. So this is the request and accept of summary of care. So we just talked about sending it, so now you're requesting and accepting. So for at least one transition of care referral, the patient, the eligible clinician that has never before seen that patient. So these are all new patients to this clinician. They go and retrieve that patient information from that transition report or referral report and pull it into their EHR, as I mentioned. So you really need to take the report and not just jam it into some sort of scanned document file and really never refer to it again. What this measure is looking at is, did you take that information? So if it's an updated medication list, problem list, allergies, demographics, any sort of progress notes, functional status assessments, really anything that might be sent over of use. If you can pull that into your record and make something of it, did it enhance your record in some way, hopefully? Again, that's increasing collaboration between clinicians and settings of care. As I mentioned before, it's all the same. Advancing care information based on performance score. It's the same improvement activities, and it's also part of that closing the referral loop quality measure. So, security risk analysis. This one can be challenging. It seems very straightforward, but it really can be challenging. Oops, and I apologize, that's her. If you guys are familiar with typing EHR on a computer, it loves to autocorrect the her. We try to capture those, but sometimes they sneak through. So, for the security risk analysis, this looks at conducting or reviewing a security risk analysis in accordance with the requirements. So 45 CFR 164.38A1. As you know, with governmental documentation, they all refer back to different elements within the rules and government structures. So this measure really looks to how are you encrypting your electronic patient health information, all of that privileged information related to date of birth and social security numbers, addresses, phone numbers, anything related to their specific conditions, so problem lists, medications, anything that can be tied back to that patient. How are you encrypting that? How are you securing it? Are you implementing security updates as necessary? So when you work with your EHR vendor, do you take the updates that they recommend? Do you also time out your EHR system on the appropriate time? So let's say if you step away from the computer, does it automatically log out, or does it take 2 minutes? How often do you require password updates? And also, while not directly included in the EHR, how do you secure your paper documentation that may be generated from the EHR? So if your team is printing out progress reports or medication lists or whatever, are they getting left on a printer somewhere for all to see, or do they get put into a shredder bin that's secured, or how is that all being secured within your practice? Now, it says conduct a review, so you don't have to do a new assessment every single year. Oftentimes practices do these every 2 to 3 years or so. They have one, I've seen external auditing companies come in, they look at every aspect of your practice and your organization to make sure you've met all the requirements. This goes back to HIPAA requirements, so the Health Information Portability Act. How are you securing all of that? And if you've already done your kind of annual assessment, you need to go back and review it at least annually to say, okay, we have some deficiencies and here's our mitigation plan. So So maybe we didn't use a lockbox before for all shredded documents, but we've implemented utilizing this system or this company, and we now have a lockbox. So why is this so important? One, it has a high probability to be included in an audit. Because it's attestation only, so as you remember I said yes, you just say yes or no, you've done it. CMS oftentimes goes after these types of measures to look at documentation. So what sort of supporting documentation do you have available to say, yes, we have this program in place, if we get a breach, this is what we do, if we, whatever the case might be. What's your process? Also, are you conducting the analysis on the appropriate timeline? So, again, I said at least once per calendar year. The other time you really need to reassess is if you do any sort of additional installation or upgrade of your system. Obviously, that's changing what was already in place. You just need to make sure you have everything in place to continue saying, yes, I've done my due diligence and my system is secure. As I mentioned, this is a unique analysis. It needs to be done within the calendar year. Oftentimes, if your organization covers multiple practice sites, each individual practice site should have its own individual analysis. You can take organizational elements, but you need to specifically identify what you're doing in that site. E-prescribing, this one's pretty straightforward. At least one permissible prescription written by the MIPS eligible clinician is queried for a drug formulary and then transmitted electronically over the EHR. If you have fewer than 100 prescriptions, let's say you just don't prescribe much, you would be excluded from this measure. And authorizations for durable medical equipment are also excluded. So if you're sending, let's say, prescriptions, but they're not really medication prescriptions for compression stockings, let's say, or other, medical toilet apparatuses, you couldn't include those. They would be excluded from this measure. This is just a great opportunity to improve medication prescribing. Some states allow for Schedule II medications to be electronically prescribed, some don't. It's a great way to look and say, okay, what are our prescribing patterns? Are we following formularies? What's our utilization? How are patients doing on actually filling these? This is an improvement activity, so implementation of a medication management practice improvement. Just a nice way to look back and see how you're doing with that. Medication reconciliation, so this is looking at how you're reconciling the patient's medications on transition. So, again, looking at medications, pretty much anyone I think in the medical field knows that oftentimes medication lists are sort of full of errors. Patients don't necessarily know what they're taking. They don't know how often they're taking it. They just decide not to take things. The other thing is if patients see multiple providers of care, sometimes they get confused going between the two settings or maybe even more than two settings. And so the medication list has the opportunity to be quite inaccurate. So if you can demonstrate that you're reconciling medications, again, that's improving accuracy in the patient's medical records, hopefully avoiding any sort of adverse drug events if maybe something didn't get documented and then it caused a drug event down the road. So just, again, improving the quality of the patient's records. As I mentioned, this covers multiple areas of performance. So it's that bilateral exchange of patient information. It's a bonus measure, so it's, again, that EHR utilization. And then you can also use this as a quality improvement, a quality measure. So if you do medication reconciliation post-discharge, so that's coming out of the hospital, you could count that also as a quality measure. Clinical information reconciliation, this is very similar to medication reconciliation. However, it's only available for those clinicians reporting using the 2015 or 2015 combo 2014 EHR. So for at least one transition of care or referral, the MIPS eligible clinician, who again has never seen this patient before, does a clinical information reconciliation. So you look at medication. So what are the patient's medications, including the name, dosage, frequency, and route of the medication. You review medication allergies, so whatever the patient says maybe their allergies are. And then, of course, you're reviewing that current problem list. So you're making sure that it's current and all diagnoses are active, and if they're no longer active, they're moved to maybe a inactive or no longer appropriate category. All problem lists are handled a little differently. Again, increase accuracy of the patient's medical record. We want to avoid any sort of adverse drug events or misdiagnoses. So really important to make sure everything is up to date. Again, this covers multiple performance areas. These are the same as before, so it's that bilateral exchange of patient information, and it's the certified EHR utilization ACI bonus measure. And again, this one can be used as closing that referral loop quality measure that I mentioned before. Because you're maybe working with a referral, you can loop that in because you would be referring the patient and making sure that the reporting is done back and that everything is accurate. Again, we like to make sure we check a couple boxes as we work on some of these tasks, because you're already doing a lot of this probably in your daily practice. I'd mentioned before, view, download, transmit. So this is looking at patients who have access to their patient portal, so that they can go in and view, download, or transmit their electronic health information to a third party. Now, oftentimes it's strictly the patient's viewing it, so they log in, they look at their problem list, they look at their after-visit summary, they look at their medication list. Some organizations have the ability to automatically transmit that to another setting of care if the patient wants. It depends on the capabilities of your portal and your EHR. This is a great way, again, interoperability, patient engagement, communication between multiple settings of care, really ensuring that the patient's data is available wherever they might be seen. As I mentioned, it's a component of the patient utilization. That's a required base measure. It's a method, again, for increasing patient engagement, and it covers a couple different areas of performance. So, improving activity of engagement of patients, family, and caregivers in developing that plan of care. So if you view, download, and transmit that record, you can say, okay, is this care plan appropriate? Maybe the patient needs to be seen by a different care provider. Maybe things within the care plan are no longer appropriate. The patient's status has changed. Their abilities have changed. They have different priorities. Whatever the case might be, it's a great way to check and sort of say, yep, we're on track, or maybe no, we need to reevaluate things. And again, it's a bonus measure for EHR utilization in the improvement activity category. Secure messaging, very similar to the view, download, transmit. So patient in the patient portal, do they have the ability to send a secure message to their clinician? Now, this measure, some might think, okay, if I send a patient a reminder, let's say through the portal, to get their immunization done on a certain date, this will qualify. Well, not quite. Really, this needs to be directed specifically to the patient, and it needs to have that response. So the patient needs to take an active role in this. It can't just be a one-way communication from the clinician's practice to the patient. It needs to have the patient or the patient's representative responding via secure message. Again, it's a component of the patient portal utilization measure we already talked about. It increases patient engagement, and it covers those multiple areas of performance. Patient-specific education is, just as it says, it's providing patient-specific education resources through an electronic means. You can utilize your EHR to identify those materials and then make them available via your portal, whatever works best for your practice. Again, it's a component of the patient portal utilization, and it covers several areas of performance. Now, these are all performance measures that you would get performance points for. Patient-generated health data. Patient-generated health data or data from a non-clinical setting. Now, this is patient data. Let's say you have a diabetic patient who is utilizing a glucometer to check their blood sugar at home that has some sort of capabilities to link into their computer system. So maybe it's a patient that's a bit of a brittle diabetic. You want to look to make sure that they're meeting your targets, and you ask them to check to see that they are within the range. They can automatically upload their data. Obviously, that's coming from a non-clinical setting because it's coming from the home or whatever other setting. They can upload that and send it right into your EHR to be included in some sort of patient-reported field. This is a really great tool if you have the capability to utilize it for patients that need that higher level of monitoring. Maybe they are a CHF patient and you want to make sure that their weights are under control, or you're trying to monitor specific symptoms, This is a great way to, again, engage the patients in their care and make sure that they're sending you data that you can then utilize in a meaningful way when the patient isn't physically sitting in your office. So really nice tool if you can get it in place. Again, it covers multiple areas of performance. So this is an improvement activity, implementation of methodologies, for improvement of longitudinal care management for high-risk patients. Again, those diabetics, CHF patients, maybe COPD patients, asthmatic patients. You can check with them on their action plans. And because it's an improvement activity that utilizes the EHR, you get bonus points. Registry reporting, we'll just touch on briefly. So again, it's all dependent on whether or not your state or your organization or specialty society has a registry even available. You can get bonus points. I lumped in the immunization reporting in this category. It's actually a separate measure, but if you can report on it, you'll get 10 bonus points. If you can't, then you won't get bonus points. And then if you do any of the other clinical data or electronic health reporting, you would get additional bonus points. So you can get a performance measure or bonus measure. If you have the capabilities, these are tremendous resources to track patient data. You can both get local, regional, national data if you can submit and then utilize data that may be provided to you by this registry. The problem is oftentimes they're not available. Getting the interface to communicate back and forth can be very costly, but they can be really tremendous clinical decision support methods with some tremendous data if you can get access to it. So again, increasing awareness and data availability for various conditions. It covers multiple practice areas. So this is leveraging a qualified clinical data registry, again, the QCDR, to standardized processes for screening. So if you have an opportunity to utilize one of those, I would highly recommend it. Just super briefly, we're going to talk about alternative payment models. As Raka mentioned, this is the second payment track of the Quality Payment Program. Oftentimes, we're located in Massachusetts, so these are often ACOs. They can also be comprehensive primary care plus models or other payment models, so the oncology care model or comprehensive end-stage renal disease model. There's some additional APMs coming in future years of programs. But so what happens if you're part of a MIPS APM or an advanced APM? So I'm going to specifically talk about the Medicare Shared Savings ACO. So this is Medicare Shared Savings Track 1, 2, or 3. So if you're part of those, you would report your advancing care information performance by your participant TIN. So this isn't the APM's TIN, so that entire entity TIN. This would be your specific practice TIN. And as you report, you would get a weighted score. So depending on the number of eligible clinicians within your practice, your performance would get weighted against all the other practices within your APM, and that would become one APM aggregate score. A little complicated because it gets weighted, but basically it all gets aggregated into one APM score. Now, what happens if you're part of an advanced alternative payment model? So let's say a next generation ACO. In this case, you would report your advancing care information performance either by participant TIN or by individual. You have the opportunity to select one or the other. And then your score just automatically gets aggregated. There's no reweighting there. It's just a straight, however you perform gets aggregated into the APM aggregate score. All of the measures are the same. The reporting period is still at least 90 days. It's pretty much exactly the same performance category, but it's really the only aspect of the APM reporting requirements that you have to submit by your participant TIN. And again, that's usually your practice. Just very, very, very briefly, because we only have about 10 minutes left, and I want to make sure we answer questions. The CMS Year 2, Quality Payment Program Year 2 proposed rule was released just about a month ago. These are some of the highlights that we've seen, the major changes that have been proposed. There's an increase to the performance threshold. CMS is proposing going from 3 to 15 performance points in order to avoid a negative payment adjustment. Again, these are all proposals, not sure where that will land when the rule is finalized. There's also talk of increasing the low volume threshold. Veronica mentioned the low volume threshold is either $30,000 in Medicare Part D claims annually and 100 Medicare beneficiaries cared for annually. With the proposed rule, that could jump to 90,000 in Medicare Part B claims and 200 Medicare beneficiaries annually. Very pertinent to our discussion about advancing care information. Clinicians will still have the ability to use their 2014 certified EHR. In the year one final rule, the rule said that by 2018, everyone had to be on 2015 certified EHR. You're allowed now to stay on 2014. If you have transitioned and upgraded to 2015, you can get some bonus points. There's creation of virtual groups. That's probably a discussion in and of itself that could take up about an hour, but there's some new opportunities there. As I mentioned, some bonus points for clinicians in small practices or those caring for complex patients. That just gives you some additional bonus points on your final score. There's also the ability to submit data via multiple methods in each performance category. So as the final rule currently stands for year one, you have to select one submission method per performance category. So one method per quality, advancing care information, or improvement activities. Now, CMS is potentially allowing you to select, let's say you can get half of your advancing care information data through your EHR, but another half of it you want to submit via attestation. Based on how the proposed rule is formulated, you might be able to do that next year. You can also get additional bonus points for performance improvement in the quality category. So if you're doing really well, you submit this year, you do well in quality, you perform even better next year, you can potentially get some bonus points. There's lots more changes that came with the proposed rule, but that's just a quick summary of what we've seen that kind of are the big jump out elements. Some resources. This is our website, http://neqpp.org. We have a great Ask a Question resource, so feel free to reach out to us there if you don't want to ask it now. This is also the CMS QPP website. It's a great resource. You can look at quality measures, advancing care information measures, improvement activities, really anything about the programs. You can check your participation status. And then I also included the link right to the proposed rule. I highly recommend everyone check that out. If you have comments, CMS does listen to comments. Please make sure you submit those. You have roughly a month. Comments are accepted until August 21st. So make sure you get those in if you have comments. That's my puppy, Lucy. She's very cute. It's almost her birthday, her first birthday. We'd like to open it up for questions now. If you have questions, we'll check chat. But then as Morgan had said, if you do #6, it'll unmute your line.
And Leila, it does look like we have some questions in chat, so I don't know if you want to go ahead and start with those while people get their phone lines unmuted.
Yeah, absolutely. Let's see. We'll go back. Okay, so from Jennifer Chamberlain, if the QPP proposed ruling is finalized as it is there exclusion? Yes. So thank you for mentioning that, Jennifer. So as the proposed rule stands, there is an exclusion. So it's, as I mentioned, for e-prescribing, it's under 100 e-prescribed prescriptions, and then also for the electronic summary of care measure, it's under 100 transitions. So again, you have to look at the transitions, not the summary sent, but the transitions. You would be excluded from reporting to those measures. Thank you for bringing that up. Let's see, next question from Jennifer. It was just stated the registry intent immunization would not count for performance points. We had research regarding So the question is about intent to participate in the syndromic surveillance. I guess the QPP help desk has said that if you have a letter of intent, that would still earn you bonus points. Thank you for clarifying that. It varies depending on how far along in the process you are. So if they're saying that a letter of intent will suffice, then that's good to know. Sometimes we've heard that it won't because you need to have a certain level of participation with that clinical data or public health registry. So, please repeat that. So the place of service codes. They are place of service 21, inpatient hospital, 22, outpatient, it's like outpatient facility, and then 23 is emergency department, and that's for the hospital-based clinician reweighting. Oops, sorry, my computer just jumped. In If you receive a transition document from another physician, is it sufficient to scan it into your record and have the EP note that they have reviewed this document? That's a great question, Susan. How are you receiving the document from another physician would be my question. Is that simply coming via fax, or I guess my question would be, how are you receiving that document from the clinician in the first place, that you would need to scan it into your record? And yes, a copy of the slides will be made available. Oh, Morgan provided that already, thank you. Nursing home visits are not related, unfortunately. Susan, are you on the line still? Do you mind jumping on and explaining how you're receiving those transition documents?
And again, Susan, it's #6 to unmute your line.
While we wait for Susan, does anyone else have any additional questions?
And Leila, I just checked the participant list, and I don't think Susan is still on the webinar.
Oh, okay. Oh, someone said, sorry, I missed the answer to my HIE question. Could you repeat it? No problem, Jennifer. So, yes, based on the proposed rule, there is a 100 prescription exclusion. So if you have fewer than 100 electronic prescriptions, you're excluded from the e-prescribing measure. And if you have fewer than 100 transitions, again, that's transitions, not summary of care documents sent, you would be excluded from reporting on those summary of care measures. Do you know if the total joint registry will report any data on quality for ortho? To do not. Joellen, thank you for asking. We don't get too involved in the registries because they all have very different requirements and submit data in very different manners. So I would say talk to your total joint registry. They might be able to. We have seen great success with clinicians that don't have EHRs. However, if you don't have an EHR, you can't pull the data required for the advancing care information measure. So it's not simply, are you, without an EHR, you're really not doing any of these activities. So I'm not sure how you would achieve credit, even utilizing the registry. If any of you would like to contact Radhika or myself, here's our contact information. We're happy to discuss anything else you might have questions about further. If you don't want to ask questions publicly, feel free to shoot us an email or give us a call. We're happy to go through it further with you.
Alrighty, Leila and Radhika, thank you very much. If there's no more questions, I just have a few follow-up details to give you guys. Thank you again for that great presentation. As you close out of this webinar, the evaluation will automatically pop up on your screen. If you haven't had a chance, or if you don't have a chance to fill that out right now, or you're sharing a computer with somebody else, you will be getting an email tomorrow with a link to the event webpage where you can find the slides as well as the recording and transcript will be added there within a few business days. So if you can make sure to do that evaluation, we would greatly appreciate it. You should have received the PowerPoint presentation. I did also put the link into chat where you can find it. But we will, if you have any other questions for our speakers, just put them in chat and we can follow up with you guys. Again, thank you for attending and we hope you had a great day.
Thank you again, everyone.
Hey, Leila?
Yes.
Are you still there? Did you see the thing that just came into chat?
Yeah, I'm looking at it right now.
Okay. I don't know if
thank you, Jennifer, for sharing that.
Still on the line.
Ryan is not ready to engage EPs will register with them.
Hello?
Hello?
Hey.
Hello?
Hi,
Hi,
go
can you
ahead.
hear us?
Did you have a question?
Yeah, is that me?
Yes.
Okay, good. I've been having trouble getting unmuted. So my name's Ken. Thanks for addressing the issue that I've been wondering about in terms of method of reporting, whether it might be claims, EHR, or registry. And I guess I think I heard the answer for next year that you could mix and match, if you will. How about for this year?
Yeah, so the proposed rule, it hasn't been finalized, so 2018 reporting says that there is potential for mixing and matching. However, for 2017, you can't mix. You have to select one method of reporting.
So that helps me a lot. I have an EHR vendor that I'm having great difficulty having them connect properly.
Yes.
So it's a big challenge. I've got 3 different registries. I'm trying to get them hooked up with, and it's a big challenge. But that addresses my question. Thank you.
Absolutely. Happy to help. Any last questions?
I think we're all set, Leila. Thank you.
Great. Thanks again.
Bye, everyone.
Thank you.
Bye.
The leader has disconnected. The conference will be terminated in 5 minutes.